This micro lesson will describe how to perform global longitudinal strain. Strain in echocardiography describes deformation of the myocardium during the cardiac cycle. It is reported as a fraction or percent. The formula is strain equals the change in length of the object divided by the original length of the object, and it can be used to assess systolic function. For strain imaging, the frame rate should be between 40 to 80 Hz. On some ultrasound systems, the frame rate may be displayed as frames per second, or FPS. Instrumentation settings that influence frame rate are imaging depth. The shallower the depth, the higher the frame rate. The sector width, the narrower the width, the higher the frame rate, and line density. The fewer lines written, the higher the frame rate. The images for strain analysis should be acquired at a consistent heart rate, and faster heart rates may require higher frame rates. Other instrumentation considerations include placement of the region of interest, or ROI. The region of interest should cover 90% of the myocardial thickness, being careful to avoid tracking beyond the epicardium, as doing so is likely to underestimate strain values. The ROI should not extend beyond the valve annulus or into the atrium, as this may also underestimate strain values. This is an example of incorrect placement of the ROI, with extension into the left atrium. The image on the right demonstrates correct placement of the ROI without extension into the left atrium. Now we will show a normal example of how to perform the strain technique.
To calculate global longitudinal strain, you'll take a 4-chamber, 2-chamber, and 3-chamber image. And to optimize this image a little bit, we want to be LV focused. So I'm dropping my depth a little bit, and I'm going to make my sector size a little smaller. And that is to just get the appropriate frame rate. When we're taking strain images, we want to see the endocardial border throughout the cardiac cycles, and we want to try to make sure that we have no translation on the image. And so I'll have the patient take a very small breath in for me, and then that way we can get our nice endocardial border image. Breathe out just a little bit and hold it right there, and we'll wait for 3 cycles. And then I'll capture that image. That makes sure it's not moving at all. You can breathe. And so we've got our nice 4-chamber image. I'll move on to my 2-chamber image. Take that small breath in again. Hold it right there. Breathe in just a little bit more. Hold it right there. And breathe. This image is moving a little bit, so I'm going to take a different one so that I can accurately track the strain. I may turn the patient on his side a little bit more just to get that really nice optimized image. So take that small breath in, and now we see that anterior wall a little bit better on this 2-chamber image. And breathe. Lastly, remember to try to go down to the farthest rib space you can. You may see an image that's foreshortened, but this will give us inaccurate values, especially at the apex. So when you see this foreshortened image, sliding down that rib space to elongate the ventricle will help us get those more accurate strain images. And then maybe you'll have the patient take a small breath in again, hold it right there, and we get a nice 1, 2, 3, and you can breathe. When we go into the automated functions of calculating strain, we'll just select one of the 3 images, and then in your measurement package under AFI, you will see the automated software for strain. What we're going to do first is label our images, and if you see here, this actually drew the ROI down into the left atrium. So I will redraw that to make sure that we're sampling the correct segments. So with a 3-click, I can get rid of my probe here, And I'm going to do it on the posterior basal annulus, the anterior septum basal annulus, and the apex. If you see on the screen, the software also guides you into where to place these points. I'll select process so that I can watch the tracking. And here we can see the myocardium tracking in all these segments except for this basal one. So I can hit reprocess and maybe adjust this segment a little bit to cover that myocardium and hope that it tracks. I'll select process again, and there we see we've got that nice and tracking again. When we look at the curves, we'd like them to be going all the same way. So down when we see aortic valve closure, and all of these little circles, all of these lowest points should be about at the same place. When we're ready for our next view, we can select approve and select next. And then we're just going to select our next image and label it as a 4-chamber image. Again, if there's any processing or adjustments you need to do on these ROIs, you can move them with the different circles here and select process. Again, we'll watch it track, making sure that we agree with the tracking of both this moving image and then also the curves up here. This basal part is a little bit low, so this is where I may want to reprocess it. But for the sake of time and showing you this, I will just approve and select next. Select my 2-chamber image, and again, I will label it as 2-chamber. Adjust my ROI points a little bit. If you find that you're adjusting more than 1 or 2 of these points, that's when you may want to redraw that ROI. You can select process, and then finally watch this last segment ROI track. If you find that there's a segment that's tracking, this basal segment looks like it's actually tracking okay, you can select that segment to approve it. And then once we have all 3 of our images, now we are able to see our bullseye and traces, and this allows us to look at all of the views all at once.
This is an example of strain imaging and a bullseye map from an echocardiogram without hypertrophic cardiomyopathy. Note the bullseye map on the right. This is an example from a patient with a hypertrophic cardiomyopathy. Note the bullseye map on the right and the areas of decreased strain in the septum and anterior septal segments. This is an example from a patient with an apical hypertrophic cardiomyopathy. Note on the bullseye map on the right the areas of decreased strain in the apical segments.